everyone. Welcome to our online course of urology. I'm Dong Xiao from the Department of Urology, the first hospital of China Medical University. Today, our topic is urolithiasis and genitourinary tuberculosis. Our topic is divided into 3 chapters. Chapter 1, renal and urethral stones. Chapter 2, bladder and urethral stones. And Chapter 3, genitourinary tuberculosis. First, let's come to Chapter 1, renal and urethral stones. Renal and urethral stones also can be considered as upper urinary tract stones. They occur more commonly in men than in women, and the whites have the highest incidence compared with Asians, Hispanics, and African Americans. The risk of stone disease correlates with weight and body mass index, and also some systemic disorders, such as diabetes, metabolic syndrome, and cardiovascular disease. The fundamental pathogenesis change in stone disease is urine supersaturated. The most common component of urinary stones is calcium, which is a major constituent of nearly 80% of stones. This table shows us stone composition and relatively occurrence. Calcium oxalate is the most common stones, comprises about 60% of all stones. Hydroxyapatite make up 20% and brushite stones make up 2%. Uric acid and straw whites each comprise about 7% of stones, and cystine stones represent only about 1%. The clinical symptoms of renal and urethral stones are pain, especially flank or back pain, nausea and vomit, hematuria, and infection, such as rigor, fever, and bladder irritation. Diagnosis of upper urinary stones usually depends on typical symptoms and medical history. Laboratory examination, imaging examination such as ultrasound, KUB, IVU, and CT scan, and also metabolic examinations. Stones manifest as strong echo with sound shadow in ultrasonography and high density in X-ray and CT scan in kidney and ureter. If the stone is less than 6 mm and there is no distal obstruction, we can choose medication first, such as alpha blocker. Surgical management of upper urinary stones includes extracorporeal shockwave lithotripsy, ureteroscopic or flexible ureteroscopic lithotripsy, and percutaneous nephrolithotomy. Okay, let's move to Chapter 2, bladder and urethral stones. Bladder and urethral stones are considered as lower urinary tract stones. Bladder stones usually occur in men older than 50 years of age and are usually associated with bladder outlet obstruction. The typical symptoms of a bladder stone are intermittent, painful voiding, and terminal hematuria, usually accompanied by bladder irritation. Urethral stones can cause dysuria. Diagnosis of lower urinary stones usually depends on typical symptoms and medical history, laboratory examination, imaging examination such as ultrasound, KUB, IVU, and CT scan, and also cystoscopy or urethroscopy. This slide shows the imaging of bladder stones. Strong echo with sound shadow in ultrasonography and high density in X-ray and CT scan, almost the same as upper urinary stones. If the stone is less than 1 centimeter, such as migratory stones from urethra, we can choose conservative treatment. Bladder calculi are best managed with transurethral cystolithotripsy with high stones-free rate and safety. Suprapubic cystolithotomy also can be performed, especially for large stones. Now let's move to Chapter 3, Genitourinary Tuberculosis. Genitourinary tuberculosis is responsible for 30 to 40% of extrapulmonary tuberculosis cases. Hematogenous spread from the pulmonary focus is the main route. Frequency is the earliest symptom, then urgency and urodinia, terminal hematuria, pyuria, lumbar pain, fever, urinary incontinence, and finally, renal failure. Scrotal mass can be found in epididymal tuberculosis. Diagnosis of genitourinary tuberculosis includes typical symptoms and medical history, laboratory examination. Culture of tuberculosis bacillus in urine is gold standard. Imaging examination such as ultrasonography, KUB, IVU, and CT scan. Typical cystoscopic presentations such as mucosal erosion and ulceration, and tubercle formation. Typical IVU changes include Carli cell irregularities, infundibular stenosis, renal loss of function, renal cavitation, urinary tract calcification, collecting system thickening, stenosis or dilatation, and contracted bladder. Photo A is the initial IVU with right kidney dysfunction and normal left kidney and bladder. Photo B is IVU after 10 months with development of contracted bladder and urethral hydronephrosis on the left. Photo C is voiding cystography, showing high-grade vesico-urethral reflux on the left as a cause of dilatation of the collecting system. CT scan shows patient with unilateral renal tuberculosis with dilatation of the collecting system and thinning of the renal parenchyma. The treatment of genitourinary tuberculosis includes pharmacological treatment and surgical treatment. Pharmacological treatment includes bactericidal drugs and bacteriostatic drugs. 18 and 24 months treatments are recommended. Surgical treatments include removal of the tuberculosis-destroyed kidney or epididymis, reconstructive for unblocking the collecting system, augmenting the contracted bladder. At least 4 to 6 weeks of pharmacological treatment is necessary before the operation. Okay, that's all. Thank you for your attention.